Ladies and gentlemen, dear Mrs. Chairman, thank you very much for the invitation to come to Vienna on this wonderful day. In opposition to Finland, I had a very short distance from the center of Vienna to come to this place here, and I took advantage of my motorcycle and came here, and I'm happy that I survived the trip here with the lots of traffic which we have due to the people going out to vacation for this day today. If by accident, it is today 150 years that famous German writer and an artist made a presentation of a story of a patient with toothache. And even then, at these times, you could see that the patient had a lot of problems with having tooth pain, that he tried different therapies, which without each of them working. And finally, he still had to move on and go to the dentist, and in pre-radiologic times it was not that easy as in that time to just take a short look into the mouth and then say, oh, this one is the tooth, the correct one, and we have to take that out. And doing trial and error, sometimes the dentist had to remove a couple of teeth before the correct one was found and extracted finally. In my presentation today, I will just go into go back very shortly to the history of dental radiology and go into dental CT, which is the term I use for multi-slice and cone beam CT as well, and finally show some cases from both devices with focus on multi-slice CT. Okay, dental radiology has the same origin as general radiology. It is begins with the detection, with the finding of the X-rays by Wilhelm Conrad Röntgen in 1895, and the first dental film images was done just a few weeks later after the detection of the X-rays. The next step was in 1949 in Finland by Patero, who invented and produced the first panoramic device. And finally, in Great Britain, the computed tomography by Sir Godfrey Hounsfield is the invention which was a very big step forward also in dental radiology. It took some time because computed tomography was considered as a device which is not able to be applied in the jaw region due to the metal artifacts. So no imaging of the alveolar crest, especially if you do coronal X-rays, coronal slices, because the whole alveolar crest is not visualized due to these metal artifacts. And it was there had to be a publication by Melvin Schwartz, who found out that meanwhile computers are powerful enough to reconstruct multiplanar images, and he said we can just very easily just make the investigation now with the patient in the supine position, and then the artifacts stay in the occlusal plane, and the occlusal plane is not very interesting for us because this one we see very easily by just looking into the mouth, and we'll see the alveolar crest just by making multiplanar reconstructions. And that was the technique which was introduced in 1987 and was since then is used on a routine basis also at our department. The next step was cone beam CT, as described earlier, which were the first publications in 1982 in the field of angiography, where cone beam CT was used. It was also, or is, still used in radiation therapy, also in interventional radiology, mammography, and the first dental application was 98 and 99 by Mozo from Italy and Arai from Japan, who described this device as ortho-CT, which was a little bit difficult to understand for most people, and so most of them settled just on calling it cone beam CT. The device, I'm not going to go into the technical details, as we heard it just prior to my session here. And the main thing is that you can very easily see the jaw region with just one rotation of the X-ray tube around the head, while the plate which moves around the head as well, makes up a complete 360 degree examination of the jaw region, and secondarily reconstructs the images. The single slice CT has a single fan beam, and meanwhile all the CT devices have gotten multiple slices, and so the fan is getting wider and wider, and meanwhile you don't have a very big difference anymore between multi-slice CT and cone beam CT. Cone beam CT is some kind of CT light. You don't have a collimation of the single slices. They are just calculated, so you have some artifacts from that. But de facto, it is like that these devices are very similar and getting more similar and similar the more time goes by. And so we have put up our first CT device in 1996 at the dental clinic, and I'm honored that Professor Robinson is here today, who was the first who was operating this device at that time then. And since then, this device is still operating there at the dental clinic and the dental school in Vienna. In 2001, there was the first cone beam device from an Italian company sent to the market. It was very large and difficult to handle. Meanwhile, you already have devices where the patient can sit or even stand, and you have about 15 companies producing these devices, each of them producing about 2 devices, so you have about 30 devices you can choose from, cone beam CT only. What is the difference in the image? You have these are 2 different patients, but you get the idea. This was one of the first images. You see that the stray artifacts in the soft tissue are very strong, so you cannot really evaluate the soft tissues at all. But the image is, other than that, quite clear. The CT was better at that time because it was much more homogeneous grayscale. But meanwhile, the newer machines have other reconstruction algorithms, so the images have become much better, much more detailed, as you have seen before. And if you compare them, the resolution has become, meanwhile, quite better than the one from multi-slice CT. This is from multi-slice CT. This is the image from the cone beam CT. So you see that there's much more detail. In this case, up there, it's the same patient. So you can compare. This is a list of the cone beam devices which are present, which you can buy. They are very different in field of view, the smallest one being 3 to 4 centimeters, the largest one 21, 25 centimeters. You have devices which can use different field of views. There are devices which have only one field of view, which have very small detector. There are devices which have only 4 centimeters field of view. And you have devices where you can also do panoramic x-rays, real panoramic x-rays on them as an addition to that. And you have devices where you can sit, where you can stand, or even lie in supine position. Generally, there are 3 types. If you talk 5 centimeters or less field of view, it's a small field device. Medium field is around 10 centimeters. These were the images which we have seen until now. And then large field, 10 centimeters or larger, where you can get most of the facial skeleton. Patient, I said, have multiple position possibilities. What is the dose which you receive? There are some publications on this, and it is quite fiercely debated. In general, this is a very good overview. You see that a multi-slice CT has quite a high dose, and but you see that some of the other cone beam CT devices also have doses which are similar to normal multi-slice CT. But you can, when you do dental imaging with a CT device, you can really go down with the dose, especially if you take a low MA. It's all high contrast structures which you are investigating. So if you do a low dose protocol, you can get down with the dose to come near to these regions which normal cone beam CT devices have. Up here, this is the multi-slice CT. Down here are different cone beam CTs. If you look at the image quality, if you do low dose dental CT, you see that the quantum noise gets a little bit stronger. But anyhow, even though this is only 1/3 of the dose of this investigation, you see that the image is quite clearly depictable and can be evaluated. We have done a little bit research and measured the different devices, how dental radiologic devices perform, and you can see that our cone beam CT, which we have from a Japanese company, is quite near to the multi-slice CT, a little bit lower, and the conventional dental film or panoramic device is much, much lower. It's much lower down here. It's by the factor of 10, 1 to 10, 1 to 15. So it is not the case that cone beam CT is a device which can do all the imaging instead of the conventional film. So the dose is still quite high, even though the manufacturers often say it's nothing, it's very low, and you can put it anywhere and use it for anything. Okay, so you get the images from the dental CT device. There are reconstructions performed by the devices, multiplanar reconstructions, so you get the alveolar crest visualized from the different slices. And you can then perform imaging for evaluating the implantology bed for the implant. Why do you have to do this? Because the alveolar crest changes with time, and especially if a tooth is lost, you get strong atrophy of the jaw. This is a young jaw. This is a jaw of an old person, and you see that you lose a whole lot of the jaw. And if you measure up, you lose the teeth, you lose the part of the jaw due to atrophy, and it's about 5 centimeters which you lose. And if your face is 15 centimeters high, it's 1/3 of your face which you lose when you lose your teeth and atrophy develops. So, and you must know when you have the jawbone how much place you have to put inside the implant, and that is the reason why we do dental CT prior to implant placement. So you avoid perforation here into the mandibular canal or perforation into the sinus. To evaluate this, we have the resorption classes which we use, which demonstrate the atrophy in class 1 to 6. This is just a process which doesn't go from 1 to 2 to 3 and so on. It depends. After you lose your tooth after extraction, if the whole alveolar is mineralized, you get a class 3, which is the best for putting an implant inside. If you lose the buccal bone lamella, you get a knife edge ridge. And if you lose both lamellas, the buccal and the palatinal one, you will get atrophy. And you still can put an implant inside this, but you have to use special techniques, augmentation techniques, to get an implant inside. These are these classes here as examples for real CT investigations. This would be the class 1 with a normal tooth inside. I have no idea why they call it class 1, because it's a normal situation. You have the buccal lamella, which is very important, is still in place. After the extraction, the buccal lamella should remain. And if it disappears due to the extraction, you get a knife edge ridge immediately. And here you see the missing buccal lamella, which has disappeared. But if you get normal mineralization in here, then you'll get this class 3 bone resorption class, which is the best one for performing, for putting an implant inside. Class 6 is total atrophy. You just have a very thin bone lamella, and you can help yourself by adding some augmentation bone or some material which replaces bone into the sinus and let it grow in, so you can put an implant afterwards inside here. I'll show you an image to this. The second criteria, so this was the resorption class. The second criteria which we are looking at when we are investigating the jaw region prior to implant placement is the bone quality as described by Lekholm and Sarb. And the best one for a dentist is the class 2 and 3. That's the one where you get the best primary fixation of the implant. If you have a class 4, it's usually too weak and too soft, the bone. When you drill the bone and put the implant inside, the implant will still be moving. If you put on a little force, you have to put it inside and leave it there for a very long time so it grows in, and hope that the atrophy doesn't continue after the implant placement and the time of waiting that it grows in before you put the superstructure on the implant. Class 1 is the problem that when you put the implant inside, you will have lots of problems with the heat which is generated on the bone implant interface, because when you put it inside, you drill it inside the implant, there is heat generated, especially at these places, which is very, very sensitive, where necrosis can appear very early on during the implant placement. So you must do it very, very slow, the insertion of the implant, or you will have a peri-implantitis, an inflammation very soon after the operation. So 2 and 3 is the best one. This is some example from these 4 classes. So 2 and 3 would be the best one. This would be a little bit too much cortical bone, or it's nearly only cortical bone in this frontal region, while in class 4 has so much fat tissue inside, very little trabecula, and a very, very thin cortical bone lamella. So there you have problems when inserting an implant. Okay, this is how the reconstructions look from the lower jaw. This is from the right lower jaw to the left lower jaw, so from here to here. And you see here, this would be a wonderful place to put an implant inside, a class 3. You see the mandibular canal here. And this is enlarged here again. You see the mandibular canal here. You can measure how much bone you have. So even the width you can measure easily and see that this is more than 10 millimeters of height. So you can choose practically any implant which you want. No special implants needed. This would be an upper jaw. Same from the right upper jaw with the maxillary sinus. This would be the midline would be about here. This is the incisive canal, and this would be the left jaw here. And there you see a strong atrophy on the side, and you see a knife edge ridge here. So you can only cut away a little bit from this knife edge ridge and take a shorter implant. That would be something like a solution when you have such a knife edge ridge. When you have the atrophy, as I said before, you can fill this atrophy part up with artificial bone or real bone taken from another place in the jaw and let it grow in. You see this is a wonderful result, no sinusitis. This would be a bad result. This is a sequestration of the augmentation material, and you have a strong sinusitis in this on the right side of this jaw. Your goal is, after having the performance made, to put an implant inside and use the whole height. So the implant is completely surrounded by bone or augmentative material in there. This would be a complication. The implant, there was no dental CT performed prior to implant insertion, so it is more on the inserted too much on the buccal side. It looked as it's enough to just put it up vertically, but in fact the implant would have had to be angulated a little bit more to the palatinal side to keep the implant inside. And beside this, you cannot say that from the panoramic X-ray. It's only possible when you do cone beam CT. And we also had another problem in this patient here, and you see that this implant was put much too near to the tooth 4-5 and 4-4. And the question is if the implant has eroded the root, and we have performed a CT, and you see that the tooth 4-4 is still completely there, so it's just a projection error. Probably the film was here, and the direction of the central beam was like this, so a part is superimposed over the root, so it was not an erosion. But of course, it's not a good result to touch the neighboring root in any case when you put an implant. Other complications are postoperatively also wrong position of the implant. The dentist didn't want to touch the mental foramen here on the right side, so he avoided it, but he went all the way into the soft tissue on the left side. And another patient where the implant was placed into the mandibular canal in the lower jaw. Another case of complication, lost implant in the left sinus. Due to operation, the doctor wanted to put inside here an implant, and it was lost. To localize it, we did a CT. The interesting case in this case was that it was not one implant, it was 2 implants. So after he lost the first one, he went and tried another one, and he lost it as well. So that is the reason why you have these both implants inside. You see also the strong sinusitis on the left side, and you have the reconstruction with the implant swimming in there. We had to take it out. These are some clinical images from the operation. You go through the sinus, and there's one of these implants. And that's the other one here, and this is after taking the implant out of the jaw. Quite a big operation to get that out. So the mace, to show you some of the more pathologic images or investigations which you can perform. I have just a short overview. I will just show a few cases concerning each of these points. But these are the main indications which you are doing dental CT next to implantology. Implantology we've seen. That is the part which we do on a daily basis. And meanwhile, the imaging of using dental CT for pathologic processes is about 2/3 of all indications. So any kind of pathologic process is more frequent than performing implantology. The dental CT for implantology. So cysts and tumors beside inflammation, impacted teeth, foreign bodies, calcifications, and traumatic injuries. So these are the typical findings of an inflammation. The first thing you see is widening of the apical periodontal space. This is the first sign of an inflammation on the tooth. You also can see it on a dental film, but it is frequently, especially if you have more roots, it's easier to see with dental CT or cone beam CT. The next sign which you have from the inflammation, of course, is the sclerosis of the surrounding tissue. This is called sclerosing osteitis. This is the jargon expression because, in fact, it's an osteomyelitis, but without bacteria. It's just a reaction of the bone. But like in this case, if you have periostal reaction, this is already the border of this inflammation becoming a real osteomyelitis. But of course, you need swelling, you need the blood report, which is compatible with osteomyelitis. So this would be a typical apical periodontitis, which is a very strong example of this case. What we can also do with multi-slice CT, which is not possible with cone beam CT, is imaging of the soft tissue. And you can, without using contrast media, you can already see this discrepancy on the left side. This is the abscess arising from the upper jaw, from the tooth 2-6, from the buccal root. You can even see it on the soft tissue window. And if you're not sure, just look on the other side and you'll see the discrepancy on the left side. And we have an image from this part here doing ultrasound, and you see this is the jaw, the upper jaw here. You see the abscess here in the sonography image. Another type of inflammation, which is from putting an implant inside and probably drilling too fast inside. So you have multiple peri-implantitis, so widening of the space around the implant. Also here, not here. This implant is okay. This is also a little bit affected by peri-implantitis. And of course, maybe there's also a dehiscence to the sinus, so you'll have a sinusitis on both sides. Cysts and tumors, also a classic indication for performing dental CT. This is an apical cyst of the tooth 4-7. Why can I perform it? I want to know, does the cyst break into the mandibular canal, which is quite positive here. Also here the border between the cyst and the mandibular canal here in the back is missing, so you can clearly say that the mandibular canal and the nerve is affected already by the cystic lesion. We can also, after treatment of such a cystic lesion here and here, we can also see how the process of regeneration, of mineralization takes place. This is prior to operation, and here you see clearly the mineralization which takes place. And there's only a small rest still missing here in the center before the mineralization is complete. Tumorous lesions, this is a compound odontoma in the upper jaw here. And you can clearly see these animal parts, which is a clear indicator that it's not just an osteoma or cementoma, that it must be an odontoma. And you also see the impacted 1-3, which is in the back of the part here. We can also not only prove cystic lesions with dental CT, we can also exclude it. This is just an artifact, no cystic lesion. It just looks as if it's something, but it was nothing. It's just a combination of the mandibular canal, the roof of the mandibular canal, the lingual cortical bone, and the back of the dental sac, of the follicular sac, which is around here, which is a normal occurrence. And so in combination, it looks like if it's a dental cyst. And also, impacted teeth is another typical indication which we can use with cone beam CT as well with multi-slice CT. These are the same patient, once with cone beam CT, once with multi-slice CT. That you see that the resolution is quite better with cone beam CT than it is with multi-slice CT, but still you can say the same. The result would be the same in any case when you talk about where the position of the alveolar nerve is. When you take out the teeth, you can also do imaging to put special implants inside, anchorage implants, to pull the teeth from the back to the front, and you can say how much bone there is in the palatal bone. Another indication is foreign bodies in the sinus. This is part of the root canal filling inside the sinus, and you see in the soft tissue window, you see a little bit calcification. This is typical of an aspergillosis, and this is the part which was taken out. You see here the root filling material and the aspergillosis, which was in the jaw, quite clearly to be seen. Another foreign body, what do you think this is? What will be your guess? It's a chewing gum. Chewing gum. Also possible from time to time to find it by accident. Traumatic injuries, of course, or we can see that it was a young patient who had pain in one of the molars after falling down with a bicycle. And what we've seen here is a shear fracture of the molars of 3-6 and 4-6 here. He was biting on the teeth and he got hit from the front. And so the teeth was sheared off in this part. And of course, when we looked on, we saw the fracture on the left side and also here the condylar fracture of the left side. This patient was released from the large hospital after just getting an X-ray, a conventional X-ray. Okay, traumatic fractures in a cone beam CT. And one thing which I wanted to add is necrosis, which is becoming more and more of a problem in the last years when you get biphosphonate therapy after carcinoma, mamma carcinoma. We see more and more patients developing necrosis of the jaw region. And this can be not only a small problem, it can be also a large problem where nearly 1/3 of the jaw gets necrotic and is sequestrated. You see the sequestration line here in the front. So in conclusion, I can say that both multi-slice and cone beam CT, which I was hopefully able to present in this short presentation, are both excellent techniques to come to a final diagnosis. They have both advantages and disadvantages. The multi-slice CT is especially disadvantages concerning resolution and price, but has advantages concerning grayscale, especially soft tissue imaging, and movement artifacts are only in one plane, not the whole investigation is suffering from the movement artifacts, while cone beam CT has advantages in resolution and price, while they have problems with grayscale and movement artifacts, which are, when you move, you have them problems anywhere. And they're quite equal concerning dose and speed issues nowadays. And last 10-second quiz case, a patient which had swallowed a tooth during an investigation. And I hope you can see the tooth in the topogram, which was searching for it if it was aspirated. And if you look quite clearly to it, you can see it here, right paravertebral in the duodenum and here you have the tooth, and you can even see that there is a carious lesion in the tooth. So it was the reason why it was extracted. Thank you very much for your attention.